Good afternoon, everybody. This is Dr. Pratik Tambe, and welcome to today's event. Today's event is the next in the TOG Experience series, and today's topic or theme, so to speak, is the fetus in focus. We have two eminent stalwarts from two opposing parts of the country, from the north and from the south, who are going to speak to us on two very important issues related to perinatology. First is Dr. Mala Srivastava, who is going to speak on delivery considerations in fetal growth restrictions. And after her will be Dr. Vidya Tobi, who is the president of TOG, and she's going to talk on fetal neuroprotection. But before we go on to the speakers, I'd like to introduce our chairpersons for today. Next slide, please. We can skip this. Yeah. Dr. Lakshmi Shikhande is the current chairperson of ICOG. She is the founder, patron, and president of the ISOPAV Vidarbha chapter. She was the chairperson of the IMS Education Committee for 2 years. She's been president of Nagpur OB-GYN Society. She received several awards, most notably the Nagpur Ratan Award at the hands of the Union Minister Shri Nitin Gadkari. She has also served as the chairperson of the HIV/AIDS Committee of FOXI a very long time ago, for which she received the FOXI Best Committee Award. And she has so many other orations, chapters, publications to her credit. We are really delighted to welcome Dr. Lakshmi Shikhande. Thank you very much for taking time out from your busy schedule. Next slide, please. We also have with us Dr. Kalpana Balamurugan. She is somebody who is well known in South and also very soon in the national stage. She's the national coordinator for the FOXI Infertility Committee. She also is the secretary of the Madurai OB-GYN Society. Very busy currently because she is organizing the South Zone Eva FOXI, which is in Kodaikanal. We were just discussing that before the beginning of the event. She is also chairperson of the Infertility Committee of TNFOG, South Zone Coordinator for the Endometriosis Committee in the past, organizing secretary for the Madurai Society's Silver Jubilee Conference in 2018. And notably, she served as the principal investigator in several clinical trials. So we'll welcome both our chairpersons. I would request Dr. Lakshmi Shikhande to introduce our first speaker, Dr. Malash.
Thank you, Pratik. Thank you so much for your kind introduction, and very good afternoon to one and all. And as usual, our Dr. Pratik Tambe has come out with a focused webinar, that is Fetus in Focus. And the first speaker for this focused webinar is none other than Dr. Mala Srivastava. She is head of Gynec Oncology Unit. She is senior consultant and professor, and at Sir Gangaram Hospital, she is Vice President ISOPAP, past President of AOGD. And friends, you can see there are n number of awards to her credit. And to name few awards, she is awardee of APJ Abdul Kalam Excellence Award. She is awardee of Subhash Mukhopadhyay Women's Health Icon Award, and she is awardee of Women Medical Professionals Award. Just to name a few, she has various other awards to her credit as well. Friend, she is a great academician, a teacher, a UG teacher, a PG teacher, and teacher in our various webinars and also in our ICOG platforms. So, Dr. Mala Srivastava, the floor is all yours, and she is speaking on delivery considerations in FGR. So, Mala, you can start.
Thanks, madam, for your kind words. First of all, I thank Dr. Pratik Tambe and for including me into this important focused webinar. And it's my pleasure to have all of you with us, Dr. Lakshmi madam, Dr. Kalpana, Dr. Vidya, with all of us. And I'm going to start my deliberation just now. Good afternoon, everyone. I hope you all can see my screen. Okay. So delivery consideration in growth retardation. Fetal growth, as defined, is the term used to describe a fetus that has not reached its growth potential because of environmental factors. The origin of the problem may be fetal, placental, or maternal, with significant overlap among these entities. The most common obstetric definition of FGR is based on sonography, an estimated fetal weight below the 10th percentile for gestational age. However, other definitions using a variety of criteria has been proposed. So when we talk of intrauterine growth retardation, the uterine size less than the uterine size less than the period of gestation. There can be oligohydramnios, and the patients may present with decreased fetal movement. Now we have to think about how do we manage these patients. Growth retardation without oligohydramnios, we can take the patient up to 38 weeks. Growth retardation with oligohydramnios, we have to think of early delivery. Now, how do you define growth retardation? There can be symmetrical growth retardation, there can be asymmetrical growth retardation. Symmetrical, there is a small head, small body. Most common cause is constitutional, but there can be genetic factors, there can be drug induced, there can be radiation factors also. Biparietal diameter is normal in symmetrical growth retardation, and abdominal circumference may also be normal. Ponderal index is normal. Cells as such is decreased in number. There can be association with other congenital anomalies and prognosis unless it is a constitutionally retarded baby. The prognosis may be poor. In asymmetrical IUGR, the head is normal but the body is small. Most common cause is placental, that is uteroplacental insufficiency, may be secondary to maternal diabetes or maternal hypertension, or there can be other causes as well. Biparietal diameter may be increased compared to the abdominal circumference. Ponderal index is decreased. Cells are decreased in number or size, but they have potential to grow once they get adequate amount of nutrition. And there can be association with oligohydramnios, and prognosis is comparatively better than symmetrical growth retarded fetuses. So how do you screen and do the diagnosis, and what's new? March 2021, they have told fetal abdominal circumference if it is less than 10 centile for diagnosis of growth restriction. Updated guidance from the Society for Maternal Fetal Medicine and American College of Obstetrician and Gynecologists now considers abdominal circumference less than 10th percentile for gestational age, which is another acceptable threshold for suspecting fetal growth retardation. Lower the percentile, the more likely the diagnosis of fetal growth retardation rather than a constitutionally small fetus. So what are the limitations? The use of a percentile to define growth retardation is problematic because it does not distinguish between fetuses who are constitutionally small versus small for gestational age. As many as 70% of fetuses estimated to weigh below the 10th percentile for gestational age are small simply due to constitutional factor, maybe because maternal ethnicity, parity, body mass index, and they are not at high risk of perinatal mortality and morbidity. There is a real possibility of classifying these normally nourished, healthy, but constitutionally small fetuses as growth restricted. An additional problem is that the use of percentiles requires an appropriate reference, and there is a little consensus on what the reference should be. Ultrasound-based standards avoid this bias, but are limited by the inaccuracy and imprecision of ultrasound affected estimated fetal weight. So how do you classify? Regardless of fetal growth restriction definition used, growth restricted fetuses may be classified as early or late or as symmetrical or asymmetrical. Early growth retardation refers to diagnosis before 32 weeks of gestation in the absence of congenital anomalies. And late growth restriction refers to diagnosis more than 32 weeks of gestation in the absence of congenital anomalies. The fetus has been growing well, and we have been calling the mother every antenatal visit. And after 32 weeks, suddenly you notice that the baby is falling behind time. So these fall into late growth restricted fetuses. Symmetrical fetal growth restriction comprises 20 to 30% of fetal growth restricted fetuses and refers to a growth pattern in which all fetal organs are decreased proportionally due to global impairment of cellular hypoplasia early in gestation. So sometimes symmetric growth retardation is thought to result from pathological process manifesting early in gestation, and most of the time they may be associated with some congenital anomalies or some chromosomal disorders. Asymmetrical fetal growth restriction comprises the remaining 70 to 80% of the growth restricted fetuses, and it's characterized by relatively greater decrease in abdominal size, that is, liver volume is reduced, subcutaneous fat is reduced, than the head circumference. Asymmetrical fetal growth is thought to result from the capacity of the fetus to adapt to a pathological environment late in gestation by redistributing blood flow in favor of vital organs, for example, brain, heart, placenta, at the expense of non-vital fetal organs like abdominal viscera, lungs, skin, and kidneys. Of course, there is always an overlap which exists between the two entities. So what is the rationale of screening for fetal growth restriction? Why do you want to know that this particular fetus may be growth restricted in the long run? And what is the rationale? How can we prevent? Ideally, prenatal detection of fetal growth restriction will provide an opportunity to employ interventions to reduce the morbidity and mortality, which is associated with growth restricted fetuses. And we all know adverse outcomes include fetal demise, preterm birth, perinatal asphyxia, poor thermoregulation by the fetus and the newborn, hypoglycemia, polycythemia, hyperviscosity, impaired human function, neonatal death, neurodevelopmental delay, and some adult onset disorders like type 2 diabetes in the long run. The ability of screening and appropriate intervention to reduce the frequency of any of these outcomes have not been proven. Harms of screening include overdiagnosis of growth restriction, leading to parental anxiety and unnecessarily costly and potentially harmful intervention, like antenatal fetal testing, induction of labor, iatrogenic preterm delivery, etc., can be fallout of overdiagnosis of fetal growth restriction. So how do we screen? Clinical method is the best method to screen. And then, of course, we have to confirm it by ultrasonography. Symphysis fundal height measurement with selective ultrasonography. This is the mode of direction. This is the direction to screen for growth restriction. First suspicion of fetal growth restriction often arises when this length is noted to be discordant with the expected size for dates. Discordancy has been defined in various ways. The most common criteria is a fundal height in centimeters, that is at least 3 centimeters less than the gestation age in weeks. That is fundal height 32 centimeter at 36 weeks of gestation. After 28 weeks, the symphysis fundal height usually corresponds in centimeter with the weeks of gestation. But if it falls 3 centimeter less than period of gestation, then it gives a suspicion of fetal growth restriction. Unless you find that the diameter of the uterus is more fuller than the height, then in that case you have to adjust it accordingly. Alternatively, a fundal height measurement below the 3rd or 10th percentile for gestational age can be used. The Integra, that is the 21st Project International published printable symphysis fundal height measurement standards for the 3rd, 10th, 50th, 90th, and 97th percentile using 8 urban population of healthy, well-nourished women. This can be used to measure the symphysis fundal height. The performance of fundal height measurements for screening of fetal growth restriction again is controversial because it is dependent on the person who is doing it. A systematic review concluded evidence was inadequate. One randomized trial to evaluate the effectiveness of this technique versus abdominal palpation for detecting abnormal fetal growth. Observational studies using symphysis pubis of fundal height measurements have reported a wide range of sensitivity. 13 to 86% of small fetuses were detected. Factors that may affect sensitivity include maternal body mass index, bladder volume, parity, and ethnic group. So, symphysis fundal height measurement with selective ultrasonography, this technique appears to perform best when all the measurements are obtained by the same clinician using the unmarked side of the tape to reduce bias and plotted to reflect fetal growth for the individual patient rather than against a standardized norm. So you have the same sonologist or the same obstetrician who is doing the ultrasonography for one particular patient and following it up. That one we do anomaly scan between 18 to 22 weeks, and then we call the patient at 32 weeks for the growth scan. If we find that at 32 weeks there is a fall or there is a fetal growth restriction suspicion also, then we call that patient frequently for subsequent ultrasonography after every 2 weeks to confirm and to predict the diagnosis of fetal growth restriction. So what about universal ultrasonography? Routine universal performance of ultrasound examination is an alternative method of screening for fetal growth restriction, but there is no consensus on the timing or number of screening examination. In general, when we do at anomaly scan 18 to 22 weeks, they are obtained at growth scan is done at 32 weeks. And everything is normal, then you may have an option of doing another growth scan at 36 weeks of gestation if the clinical situation arises like that. But if you have to do only one examination, then one examination is done between 32 to 36 weeks of gestation, and the predicted performance higher nearer 36 weeks. So how do you have an approach to screening for fetal growth restriction in single-trip pregnancies in the third trimester? If the patient is at low risk for growth restriction and an appropriate candidate for serial fundal height measurement, you think she is the candidate, you can do serial symphysis fundal height measurement. So if the fundal height is increasing appropriately and concordant with the gestational age, if it is yes, you do routine antenatal care. If it is no, then you do ultrasonography examination to see the effective fetal weight, abdominal circumference, or amniotic fluid volume. If it is normal, you go back to routine prenatal care. And if it is abnormal, then you switch on to umbilical artery Doppler surveillance, NST, biophysical parameters, timing of delivery is based on the results of fetal testing and gestational age. If you think that symphysis fundal height is not appropriate, then in that case, you have to start performing serial ultrasound examination again for effective fetal weight, abdominal circumference, and amniotic fluid volume. The number and frequency depends on the patient's level and risk of fetal growth restriction. If the umbilical blood flow is normal, Dopplers are normal, only you find there is a growth restriction, then you have to repeat every 2 weeks. But if there is abnormal Doppler flows, then you may have to repeat every week. If one screening examination is performed at 32 to 36 weeks and two screening examinations performed at approximately 32 to 36 weeks. If ongoing screening is indicated because of high risk, perform first examination at 20 weeks, 28 weeks, and then repeat 3 to 4 weeks. Normally, if the patient is a known diabetic on insulin, or she is a case of gestational diabetes diagnosed after 24 weeks, then definitely one baseline ultrasonography is done at 28 weeks. If everything is normal, then we can repeat it at 32 weeks. But if we find at 28 weeks, there is a suspicion of growth restriction, then we repeat every 2 weeks. And if we find that there is actual growth restriction, then we add Doppler flows to our routine ultrasonography. After doing all this ultrasonography, if we find that it is normal, then we switch on to the routine prenatal care. If we think it is abnormal, then we have to think about Doppler flows Umbilical artery Doppler flows, NST, biophysical, and timing of delivery again is based on the fetal testing and gestational age and how good your NICU care is. Evidence of universal ultrasonography. In 2019, meta-analysis of 21 cohort studies of screening ultrasound at more than 32 weeks of gestation in low-risk or non-selected singleton pregnancies, they found model sensitivities of abdominal circumference and effective fetal weight less than 10 centile at a 10% false positive rates were 78 and 54% effectively. In a meta-analysis of 13 controlled trials, including nearly 35,000 women, perinatal mortality was similar for patients undergoing routine versus no concealed selective ultrasonography. And none of the trials reported on neurodevelopment outcomes at age 2. A subsequent prospective study reported sensitivity for detection of small for gestational age infants was higher with universal than with selective ultrasound screening. But this does not lead to a significant reduction in composite severe adverse perinatal outcome. Because once at one end we are doing universal ultrasonography, 18 to 22 weeks, then 32 weeks and 36 weeks. There are more chances of picking up fetal growth restriction. But if you are doing only one ultrasonography between 32 to 36 weeks, then definitely there are lesser chances of picking up fetal growth restriction unless we are doing it more closer to 36 weeks. Special population, suboptimally dated pregnancies when the gestational age is not known with reasonable certainty. A single ultrasound examination may not be able to distinguish a small for gestational age fetus from an appropriately grown fetus that is less far along in gestation than expected from menstrual dates. So serial sonographic examinations at 2-week intervals can be useful when we think that a pregnancy dating is suboptimal. In multiple gestation, growth in multiple gestation diverges from that in singletons in the late second or early third trimester. Smallness of one or both fetuses of a multiple gestation can be related to any of the disorders that cause fetal growth restriction in singleton pregnancies, as well as special disorders, which is unique to multiple gestation, such as unequal placental sharing or twin-to-twin transfusion syndrome. So these fall into special category. So how do you evaluate and manage fetal growth restriction? Initial approach is to confirm the diagnosis. The characteristics that support a diagnosis of constitutional small fetus include modest smallness, that is, effective fetal weight between 5th and 10th centile, normal growth velocity across gestation, interval growth is normal, normal physiology, that is, normal amniotic fluid volume and umbilical artery Doppler, abdominal circumference growth velocity above 10th centile, appropriate size in relation to maternal characteristics like height, weight, race, ethnicity, as decided by Society for Maternal Fetal Medicine. So again, we have to confirm the diagnosis. Maternal characteristics have a major influence on fetal growth potential. For example, when race and ethnicity was taken into account, 5th percentile for white, Hispanic, Black, and Asian women were 2790, 2633, 2622, and 2621 grams. Like we belong to the Asian population. For us, the 5th centile is 2621 grams. In a prospective study of 2,300 healthy women with low-risk singleton pregnancies from 12 medical centers in the United States. So using a lower threshold to define growth restriction may help distinguish the small fetuses at increased risk of adverse outcome from the small fetus at low risk. So we are using lower threshold for defining pathological fetal growth restriction is also supported by several studies. In a retrospective studies, composite fetal morbidity at less than 5th percentile versus 5th to 10th percentile was 39, and 13% respectively. Although less than 5th percentile as a threshold for fetal growth restriction captures the group of fetuses at the highest risk for adverse outcome. Those at 5th to 10th percentile still need to be monitored closely since not all are constitutionally small. There may be a big fragment of growth restricted fetuses in this group as well. Next, we have to determine the cause of growth restriction. The genetically predetermined growth potential of the fetus can be impaired as a result of maternal, placental, or fetal processes. That a complete history has to be taken. A physical examination is performed to assess for maternal disorders that have been associated with restricted fetal growth. In addition, few laboratory tests, especially we have to look for anemia, we have to look for gestational diabetes, obstetric imaging are also performed to look for fetal and placental etiology. However, in some of the cases, the cause for growth impairment cannot always be determined antenatally. A detailed fetal anatomic survey should be performed in all cases since approximately 10% of growth-restricted fetuses are accompanied by congenital anomalies, and 20 to 60% of malformed infants are small for gestation age. So this is a big group of fetuses which we can catch early. Anomalies associated with fetal growth restriction include omphalocele, gastroschisis, diaphragmatic hernia, skeletal dysplasia, and some congenital heart defects as well. Sometimes we may have to do fetal echocardiogram if the result of an expert ultrasound examination suggests any uncertainty that the heart is abnormal. Now, there is a role of fetal genetic studies as well. Fetal genetic studies are indicated in any of the following settings because of the increased risk of an abnormal. Fetal growth restriction, that is all for the following: early, that is less than 24 weeks, and severe, less than 5th percentile, and symmetrical. Because we have seen symmetrical growth restricted fetuses, the 30% chance that they may be having congenital anomaly as well. Fetal growth restriction with major fetal structural abnormalities, fetal growth restricted with soft ultrasound markers associated with increased risk of aneuploidy, such as thickened nuchal fold, choroid plexus cyst, and abnormal hand position. Placental findings suggestive of a partial molar pregnancy and large cystic spaces and increased echogenicity of chorionic villi sometimes can be associated with early fetal growth restriction. ACOG suggests genetic counseling and offering diagnostic testing for patients with diagnosis of fetal growth restriction before 32 weeks or fetal growth restriction in combination with polyhydramnios of fetal malformation. Ultrasound examination has high sensitivity for identifying trisomy 18 as high as 100% when performed by an experienced ultrasonographer at 19 to 20 weeks of gestation in a fetus with multiple structural anomalies characteristics of the syndrome. Although the finding of symmetric fetal growth restriction prior to 24 weeks of gestation is associated with high risk of aneuploidy, this is no longer the case later in gestation. After 24 weeks, normally we do not screen for fetal genetic abnormalities if anatomy is normal and fetal growth restriction is asymmetric. Since the yield would be low, etiology is most likely maternal or placental disorder, and pregnancy termination is generally not required. In a systematic review of 14 observational cohort studies, including 874 apparently isolated fetal growth restricted cases, the mean rate of chromosomal anomalies was 6.4%, and no abnormal karyotypes were found in the 2 studies of apparently isolated fetal growth restricted diagnosed in the 3rd trimester. So how do you also work up for infection? Infections associated with fetal growth restriction include cytomegalovirus, toxoplasmosis, rubella, and varicella. Amniotic fluid DNA testing can also be performed for specific infection when indicated by the clinical setting. Malarian pregnancy can also cause fetal growth restriction and should be considered in endemic areas. Maternal COVID-19 does not appear to be associated with increased prevalence of fetal growth restriction because vertical transmission from the mother to the fetus has not been proven. However, data on perinatal outcomes when the infection is acquired in early pregnancy are limited, and any condition that results in prolonged maternal hypoxia places the fetus at risk for growth restriction. Although early onset placental insufficiency is one of the clinical criteria for diagnosis of APS by expert consensus, a link between antiphospholipid antibodies alone and fetal growth restriction has not been established, and there is insufficient evidence to support screening all women with fetal growth restriction for these antibodies. Indications for screening include a past history of fetal loss and prior unexplained arterial or venous thromboembolism. Then and then only we work up for antiphospholipid syndrome, and there's of course a specific indications for doing a workup for APS. So how do you manage? Management of fetal growth restriction in structural and chromosomally normal fetus, most of these cases are caused by uteroplacental insufficiency late when it is diagnosed later in pregnancy. Management of FGR associated with congenital or chromosome anomalies depend on the specific abnormality and is beyond, and then we are not going to discuss that. The optimal management of the pregnancy with suspected growth restriction related to uteroplacental insufficiency consists of serial ultrasound evaluation of fetal growth velocity, biophysical profile, and then we are also seeing whether the umbilical blood flow is altered or not, and some venous vessels as well. The purpose is now to identify those fetuses who are at highest risk of perinatal demise and who may benefit from delivery, and we have to also time the delivery depending on this particular case, mother's gestational age, mother's Doppler flows of the fetus, and then we have to take a decision regarding the time of delivery and mode of delivery. Women with pregnancies complicated with fetal growth restriction may maintain normal activities and usually monitors at outpatient. And there are no data on which to base indications for hospitalization. We have to consider hospitalization for selected women who need daily or more frequent maternal or fetal assessment. Suppose the patient has absent end diastolic flow. In that case, the patient needs hospitalization because in that case, we have to do Doppler study every day till we reach a reverse diastolic flow, and then we have to take a decision for delivery. Hospitalization provides convenient access for daily fetal testing and allows prompt evaluation and intervention in the event of decreased fetal activity or other complication. But there is no evidence that hospitalization or bed rest improves fetal growth or outcome. All the decisions about selecting women for ambulating versus in-hospital care should be made on a case-to-case basis. We generally admit women with absent or reverse flow for the umbilical artery and estimated fetal weight more than 350 grams. This cutoff is based on the experience of good short and long-term outcomes in such cases. Ideally, a course of antenatal betamethasone should be given to pregnancies less than 34 weeks of gestation in the week before preterm delivery is anticipated. Administration between 34 to 36 plus 6 weeks does not appear to decrease the need for respiratory support and increases the rate of neonatal hypoglycemia, but is recommended by some guidelines. Timing is estimated based on multiple factors, including the severity of growth restriction, Doppler findings, comorbid conditions, and rate of deterioration in the fetal status. There is no convincing evidence that any intervention in healthy women improves the growth of growth-restricted fetuses. Numerous approaches have been tried in small randomized trials, including maternal nutritional supplementation, oxygen therapy, interventions to improve blood flow to the placenta, such as plasma volume expansion, low-dose aspirin, bed rest, and anticoagulation. Sildenafil has been tried and appears promising and has been under investigation, there has been a multicentral Dutch trial of sildenafil for treatment of poor prognosis, early onset fetal growth restriction, but it was halted early because of a higher than expected rate of pulmonary hypertension in the intervention group with no benefit in the primary outcome. At the time, so the trial was stopped. There was no benefit in perinatal mortality or major neonatal morbidity. A concurrent trial in Australia and New Zealand reported sildenafil had no effect on fetal growth velocity after diagnosis for growth restriction before 30 weeks, but no adverse effects on newborn. In hypertensive pregnant women, antihypertensive therapy does not improve fetal growth. In smokers, an intensive smoking cessation program may be of value and has other pregnancy and health benefit. Timing of delivery according to the GRID trial. There's little consensus about the optimum time to deliver the growth restricted fetuses. Following key trials attempted to answer the question of when to intervene in these pregnancy without a clear consensus. The growth restriction intervention trial randomly assigned pregnant women between 24 to 36 weeks gestation with fetal growth restriction to immediate or delayed delivery if their obstetrician was uncertain about when to intervene. 40% of these pregnancies had absent or reversed end diastolic umbilical artery flow. In the delayed delivery group, delivery occurred when the obstetrician was no longer uncertain about intervening, which took a median 4.9 days. The immediate delivery group had a fewer stillbirth, 2 versus 9 with delayed delivery, but more neonatal and infant death, 27 versus 18, especially when randomization occurred before 31 weeks. Follow-up data up to 13 weeks showed no differences between groups in cognition, language, motor, parent-assessed behavior scores on standardized tests. Follow-up was achieved in approximately 70% of survivors. Cognition scores were close to the standardized normal range. Then there was a DigiTAC trial, disproportionate intrauterine growth interventional trial at term, which randomly assigned 650 pregnant women over 36 weeks of gestation with suspected fetal growth restriction to induction of labor or expectant management. The primary outcome was a composite measure of adverse neonatal outcome, that is death before hospital discharge, 5-minute APGAR score less than 7, umbilical artery pH less than 7.05, or admission to the intensive care unit. Neonatal morbidity was analyzed separately using morbidity assessment index for newborn score. The authors concluded that both approaches were reasonable and choice should depend on case-to-case basis and on patient preference. However, in a sub-analysis of the data, they also reported that neonatal admissions were lower when growth-restricted fetuses were delivered after 38 weeks of gestation, which suggests a benefit of deferring delivery until 38 weeks of gestation as long as the fetus is closely monitored and in the absence of other indications for an early delivery. What about the truffle study? Truffle assessed whether changes in the fetal ductus venosus Doppler waveform could be used to guide timing of delivery of growth-restricted fetuses with a high umbilical artery Doppler pulsatility index, instead of the conventional approach using cardiotopography short-term variation. The primary outcome measure was survival without neurodevelopment impairment at 2 years of age. Pregnancies were randomly assigned to one of 3 monitoring approaches: cardiotopography with delivery for reduced short-term variation, ductus venosus monitoring with delivery for early ductus venosus changes, or ductus venosus monitoring with delivery for late ductus venosus changes, that is A wave indicating absent or reversed flow. Their observation clearly demonstrated the need for additional study for the most appropriate methods to determine delivery timing in the very preterm, that means less than 32 weeks of gestation in growth-restricted fetuses. What about route of delivery? An unfavorable cervix, it is not an indication to avoid induction. In the secondary analysis of data from Digitat and Hypitat trials, pregnancy complicated with fetal growth restriction and hypertension, induction of labor at term in women with median Bishop scores of 3, ranging from 1 to 6, was not associated with a higher rate of cesarean delivery than expectant management. And approximately 85% of women in both groups achieved a vaginal delivery. Prostaglandins or a balloon catheter was used for cervical ripening. In a meta-analysis of observational studies of labor induction with misoprostol, dinoprostol, or mechanical methods in fetal growth restriction, mechanical methods appear to be associated with a lower occurrence of adverse intrapartum outcomes, but a direct comparison among methods could not be performed. However, when the indication for delivery is persistent reversed flow of the umbilical artery, patients were given the option of a scheduled cesarean birth, especially when the cervix was unfavorable, because many of these fetuses will not tolerate labor and they wish to avoid adding an acute insult on a chronic hypoxic fetuses. And what about intrapartum management? It is important to optimize the timing of delivery, perform continuous intrapartum fetal monitoring to detect non-reassuring fetal heart rate patterns suggestive of progressive hypoxia during labor, and provide skilled neonatal care in the delivery room. Umbilical cord blood analysis should be considered as a component of establishing baseline neonatal status. Antenatal test, that is NST or biophysical profile, is normal. A trial of labor with continuous intrapartum monitoring is reasonable. However, frequency of cesarean delivery for non-reassuring fetal heart tracing is increased, given the increased prevalence of chronic hypoxia and oligohydramnios among these fetuses. For fetuses who are less than 32 weeks of gestation, Maxsulf is given before delivery for neuroprotection together with the steroids. When use of Maxsulfate was studied, specifically in pregnancies with growth-restricted fetuses, a decrease in significant neurodevelopment impairment and death was definitely observed. So what about the prognosis? Fetal newborn childhood outcomes, fetal demise, neonatal death, neonatal morbidity, and abnormal neurodevelopment outcome are more common in growth-restricted fetuses than in those with normal growth. The prognosis worsens with early onset fetal growth restriction, increasing severity of growth restriction, and absent or reversed end diastolic flow on umbilical artery Doppler. In a systematic review of studies of fetal growth restriction diagnosed before 32 weeks of gestation, the frequencies of fetal and neonatal death were 12 and 8% respectively. The more common neonatal morbidities were respiratory distress syndrome, 34%, retinopathy of prematurity, 13%, and sepsis, 30%. Among children who underwent neurodevelopment assessment, 12% were diagnosed with cognitive impairment and or cerebral palsy. The quality of evidence was generally rated as very low to moderate, except for 3 large, well-designed randomized trials. When all pregnancies with fetal growth restriction are considered, regardless of gestational age at diagnosis, the risk of fetal death is approximately 1.5% at less than 10th percentile and 2.5% at less than 5th percentile for gestational age. What about the childhood? Long-term outcomes. An association has been observed between the poor fetal growth, early accelerated postnatal growth, and later development of obesity, metabolic dysfunction, insulin sensitivity, type 2 diabetes, cardiovascular, and renal disease. This association has been attributed to partial resetting of fetal metabolic homeostasis and endocrine systems in response to in utero nutritional deprivation. The combination of prematurity and severe growth restriction increases the risk of long-term neurodevelopment abnormalities and decreased cognitive performance. And what is the prognosis for the mothers? The birth of a newborn with idiopathic growth restriction is restrictive. Yes, just I'm winding up. Coronary artery disease, myocardial infarction, Assist pooling was not performed because of variation in the exposure definition among studies. Recurrence. There is a tendency to repeat small for gestational age deliveries in successful pregnancies. A prospective national cohort study from Netherlands reported that the risk of a non-anomalous small for gestational birth in the second pregnancy of women whose first delivery was SGA versus not SGA was 23 and 3% respectively. The association with the birth of a SGA infant in a first pregnancy and stillbirth in a subsequent pregnancy was illustrated by analysis of data from Swedish birth register. The recurrence rate, the highest risk of stillbirth is a woman who delivered a preterm small for gestational age infant. Another study suggested a sibling delivered after birth of an SGA infant was increased risk of sudden infant death syndrome. So how do we prevent this fetal growth restriction in subsequent pregnancy? Then we have to address potentially treatable causes like smoking, alcohol, chemoprophylaxis, mosquito avoidance in areas where malaria is prevalent, balanced energy protein supplementation in women with significant nutritional deficiency, avoiding a short or long interpregnancy interval may also be beneficial. Low dose aspirin may be effective when fetal growth restriction is secondary to preeclampsia, since aspirin appears to reduce the risk of developing preeclampsia in women at moderate to high risk of developing the disorder. In a meta-analysis of 45 randomized trials of low-dose aspirin for prevention of preeclampsia and growth restriction in women at high risk, aspirin prophylaxis markedly reduced the incidence of fetal growth restriction compared to placebo or no treatment. Low-dose aspirin is not recommended in the absence of risk factors for PIH. Anticoagulation with unfractionated heparin or low molecular weight heparin does not reduce the risk of recurrent placenta-mediated late pregnancy complications such as growth restriction. If we use ecosprin, aspirin together with low molecular weight heparin, definitely it prevents or improves growth restriction, but low molecular weight heparin alone does not that. These data support avoidance of anticoagulation in women with previous placenta-mediated disease, given the lack of clear benefit and potential risk of anticoagulation, cost and inconvenience. The combination of low-dose aspirin and low molecular weight heparin does not appear to be more effective than aspirin alone. So dietary changes and supplementation, you can use antihypertensive therapy for hypertensive women, beta mimetics, bed rest, but they do not prevent fetal growth restriction. They may control the blood pressure of the mother. So how do you manage in subsequent pregnancy? Accurate dating by early ultrasonography is important to establish gestational age and intermittent ultrasound examination to monitor fetal growth. Otherwise, all the routine antenatal management is same. If fetal growth is normal, fetal growth restriction previous pregnancy is not an indication for antepartum fetal surveillance with non-stress test, biophysical, or umbilical artery growth velocity. To summarize, evaluation and management of suspected fetal growth restriction, accurate determination of gestational age, confirm the diagnosis, distinguish between constitutional small and growth restricted fetus, monitor the fetal weight trajectories, managing maternal comorbidities, serial assessment of fetal well-being, and sometimes you have to take a decision for preterm delivery whenever it is indicated. Delivering hope, safeguarding futures, careful consideration now for growth restricted fetuses. Thank you for your patient listening.
Thank you, Dr. Mala, for your very informative, in-depth lecture on delivery considerations in FGR. I'm sure each and every delegate must have benefited, and you have given clear-cut take-home messages for this very, very vital aspect, because we always wonder how to deliver, how to protect baby. I'm sure Vidya will cover the neuroprotection aspect, but it was a very well delivered and informative lecture. Thank you, Mala.
Thank you,
For
Dr.
your
Mala,
kind
for
words.
being here. Fantastic talk. I think we all learned a lot from it, starting from the very basics all the way up to post delivery long term prognosis for the babies which is something that we often ignore. We don't really talk about it much, but that has to be the focus. We as obstetricians have to give a good future and a bright future to these children once they go back out into society. I'm very pleased to announce that we have over 1,300 live logins, and I'm pretty sure that number is going to not drop, but it's only going to increase once we have the president of Kasoga speaking to us.
Yes.
Can I request Dr. Kalpana to please introduce our next speaker?
Thank you so much, Pradeep sir, for your wonderful opportunity that has been given to me, and the number of viewers that indicates the credibility of the CME, which you have been organizing. Fetus in Focus. We had wonderful discussion by Mala Srivastava ma'am, and now we have our own ma'am, Vidya Tobi ma'am, who is going to talk about fetal neuroprotection. It is my privilege to introduce Vidya Tobi ma'am, who is the current president of Kazoga, who is very dynamic over the past few months, and past committee chairperson of Food and Drug Committee. And actually, we are missing you, ma'am. Recently, only I came to know that you couldn't manage to reach Kodaikanal. We have been waiting for you, but we are missing you, ma'am. And madam doesn't need any introduction, but formally, let me introduce ma'am. President Kasoga, 23 to 24, Professor and HOD of Alamin Medical College, Jaipur, Chairperson Food and Drug Committee, 18 to 20, received Best Committee Award for her activities in the FOGSI ICOG Governing Council member, 21 to 23, received FOGSI Champion Award, National Corresponding Editor of JOGI, Organizing Chairperson of various prestigious conferences, Kasoga, 2016, President Bijapur Urdu Society 2009, and she has got various publications to her credit. And she has been invited faculty in various national, international conferences, and advisory faculty of boards, Rajiv Gandhi University of Health Sciences. And Madam has got a very rich experience, teaching experience and clinical experience for the past 30 years. It's our privilege to have you here in this prestigious forum, ma'am. Over to you, ma'am.
Thank you very much, Dr. Kalpana. Really, I'll miss the Vice Presidential Conference. I know that. And I'm extremely thankful to Dr. Pratik. We know how academically he always discusses various problems, and his all talks are evidence-based. So always I remember whenever I talk about Pratik, it is always evidence-based, and I always relish to listen from him as well. And it is always a pleasure when he invites us. So I will be talking today something about the neuroprotection of magnesium sulfate, and this is my screen. And if I am able to share my screen, shall I try, Dr. Pratik? This has been shared by, I think, Shrutika.
No worries, ma'am. Whichever way you're comfortable.
Because once I go on talking, she should change the slides, and every time I should have to tell, no?
Yeah.
Shrutika, please let me share, and then if it is not possible, then you can. Shrutika? Yes.
Can you stop sharing so that madam will try?
Yeah, I will just try. If it is not possible, then many times it is not possible because...
It's done now. Ma'am, you have to make it full screen, that's all.
Yeah. But the above one screen is coming from above. How to make it?
You have to slideshow from beginning. Slideshow.
Yeah, I think she's done from beginning, but unfortunately, I think it's not working.
Okay,
so we'll go back to Shrutika.
Yes, yes.
Yeah. Shrutika,
yes.
please go ahead. Let us continue.
Yes. Yes. So thank you, Dr. Pratik, for those kind words. And really, it is a pleasure to be amongst all, and especially Kalpana here. So next slide, please. Shrutika, can you change once I start talking and then, okay?
Sure, ma'am.
Yeah. Thank you very much. And this is just what we know how the magnesium sulfate is used in various diseases. So in obstetrics, we all know its role in eclampsia. The most common indication is eclampsia. The second one is preterm labor, and third one is fetal neuroprotection. So we all term labor, which is progressive survival. And also it is important, which are used just to delay the active phase of labor for at least 48 hours for just taking the in utero transfer or our steroids to act. So magnesium sulfate, which is and then various prostaglandin inhibitors, calcium channel blockers, and nitric oxide releasing drugs, they have shown benefit in these women. We rarely use magnesium sulfate tocolytics, but it is one of the major, so many studies are available. Magnesium sulfate as a tocolytics. So magnesium labor is very well established, and the first report about the magnesium sulfate as a tocolytic was published in 90 literature, that is in 1983. The outcome of 355 patients who were treated with magnesium sulfate were reported, and these patients had multiple other morbidities, such as amnionitis, placental abruption, premature rupture of membranes, or advanced cervical dilatation. Am I audible?
Ma'am, your voice is
Hello?
breaking. Can you keep your video off for some time?
Yes, I have made my video.
Yes, ma'am, please go ahead.
We were defining about the preterm labor and no, what is preterm labor and the use of magnesium sulfate. Can you move the slides, Shrutika? Yes. So the first report about the magnesium sulfate as a tocolytic agent was published in 1977, and it was the largest case series in the literature in 1983. The outcome of 355 patients who were treated with magnesium sulfate were reported, and these patients had other comorbidities as not comorbidities. They had a morbidity such as amnionitis, placental abruption, and premature rupture of membranes or advanced cervical dilatation. And in singleton gestation with intact membrane, they found out that what was the outcome was 76% gained 48 hours before delivery, 51% gained 7 days, and 39% achieved full-term delivery. Next slide, please. Yes. So there are various clinical trials where the magnesium sulfate was compared with the placebo, and in this study, which was aimed to investigate the effect of magnesium sulfate on delay in reaching active phase of labor in women with premature rupture of membranes and subsequent fetal complications. 92 women with PROM were taken up, and in interventional group, 4 gram of magnesium sulfate was given administered over 20 minutes. 2 gram was given per hour, which was also given by infusion, and this was continued for 24 hours and after cessation of uterine contractions. The placebo did not receive, group did not receive anything, but just they were observed, and these both groups received a corticosteroid, 1 gram of oral azithromycin and ampicillin 2 gram intravenously every 6 hours for 48 hours, followed by amoxicillin, which was 500 milligram orally 3 times a day for additional 5 days. So these were given, and then the outcome was studies, that is magnesium sulfate caused a delay in delivery for at least 48 hours. Also, magnesium sulfate increased this period 2.7 times the same as in control group. At gestational age less than 30 weeks, magnesium sulfate led to a delay in 77% of women, 87.7% at 30 to 31 weeks, and 72.7% at 32 to 33 weeks of gestational age. So this was there was an average latency in the active phase when the magnesium sulfate was considered. Next slide, please. So the chance of respiratory distress syndrome in infants who had received magnesium sulfate was 80%, less than those who had received placebo, and there was no case of chorioamnionitis or adverse effects which was reported. The conclusion was magnesium sulfate delays the active phase of labor in mothers with PROM and prevents adverse birth outcomes. Magnesium sulfate also was compared with the nifedipine, where 192 women in active preterm labor at 24 to 33 weeks of gestation were studied, and all patients received betamethasone and antibiotics. In interventional group, the 4 gram bolus dose was given by maintenance and followed by the maintenance dose of 1 gram per hour. And these patients were allowed additional 2 gram of magnesium sulfate by physicians, the boluses as needed, and to increase the infusion rate up to 4 gram per hour. In nifedipine group, they had given 10 milligrams sublingually every 20 minutes for 3 doses total, followed by 20 milligram orally every 4 to 6 hours based on physician judgment. The primary outcomes was arrest of preterm labor, defined as prevention of delivery for 48 hours with uterine quiescence. The result was results were judged, and the arrest of preterm labor in magnesium sulfate group was observed up to 87%, nifedipine group around 72%. So all other parameters like gestational age at delivery at in 48 hours, and neonatal outcome were similar between two groups. The patients who received magnesium sulfate achieved the primary outcome more frequently. So magnesium sulfate inhibits uterine contractions, delays delivery by delaying the active phase of labor, it arrests the preterm labor, and significantly reduces the incidence of respiratory distress syndrome. But hardly we use magnesium sulfate as an tocolytics, because better tocolytics are available with us. Issues with prematurity. So what are the issues with the prematurity when we talk of the role of magnesium sulfate in preterm births? The preterm babies are babies who are born before term. They have got many morbidities and mortalities. They have got many other problems like respiratory distress syndromes other than the neural problems. And those who survive, they have neurological impairments, include cerebral palsy, cognitive dysfunction, what we call it is a motor dysfunction, educational difficulties as well, and even psychiatric disorders in adulthood with increased educational and social cost. So role of magnesium sulfate when we decide here, and when we talk of neurological impairments, there are pathologically two neurological injuries. One is intraventricular hemorrhage, and usually which is diagnosed by ultrasound. Second one is white matter injury, usually diagnosed by MRI. Clinically, most frequent adverse CNS outcomes, one is cerebral palsy, cognitive impairment, blindness, deafness, and developmental delay. Yes. So cerebral, when we talk of cerebral palsy, which affects the movement, muscle tone, motor skill, and its prevalence is 1.5 to more than 4 per 1,000 live births or children of a defined age range. It increases due to increased survival of premature infant, of course, but there are various causes other than the asphyxia. We can so many causes are there for cerebral palsy, not only one. So ultimate outcome, what we do is perinatal deaths, and the neuronal outcome, what we always aim at, outcome we aim at. Next slide, please. So magnesium sulfate for neuroprotection, there are multiple mechanisms. One is there is a non-competitive antagonist of glutamate, NMDA receptor. There is increased extracellular magnesium, which blocks the calcium influx into the cell. It blocks the neuronal injury. It stabilizes the membranes, increase cerebral blood flow, prevention of large blood pressure fluctuations, reduction in pro-inflammatory cytokines, and of course, it has got some antioxidant effects. By these methods, magnesium sulfate acts and gives some neuroprotection in the neonates. Although the maternal administration of magnesium sulfate has not been associated with decreased risk of fetal brain injuries as such that are believed to cause cerebral palsy. As I told, there are various causes of cerebral palsy, like severe intraventricular hemorrhage or cystic white matter injury. They have postulated, and it has been associated with the reduction in cerebellar hemorrhage in preterm infants. Next slide, please. So there are various evidence of efficacy from various randomized trials and meta-analysis. And always we talk of these evidence of neuroprotective effects of magnesium sulfate, which is based on data from randomized trials and meta-analysis of these trials. There is significant heterogeneity among these three major trials, which are designed specifically to assess the neuroprotective benefits of magnesium sulfate. First one is Australia-Asian collaborative trial of magnesium sulfate, that is magnesium sulfate. And the second one is a famous BEAM trial, that is beneficial effect of antenatal magnesium sulfate trial. And third one is a PREMAC trial, that is prenatal magnesium sulfate trial. And it is very important to emphasize that these combined outcome of cerebral palsy or death is important methodologically, as cerebral palsy and death are competing outcomes, that is death precludes subsequent diagnosis of cerebral palsy. So many they have done, and this is just, I have put it in the graph from up to date, that these are the main three trials we always talk of. Of course, we will be discussing these trials in the further we can talk of these trials, but it has got a different heterogeneity, as it was commented. The number of subjects also differ. In acto magnesium sulfate, that is around 1,000, and BEAM trial, it includes 2,241, PREMAC around 572. The dosage also in BEAM trial, they have taken around 6 grams, including the dose followed by 2 grams per hour for maximum of only 12 hours. Whereas in the first trial, that is Australian-Asian magnesium sulfate trial, that is they have given only 4 grams. So they have, we cannot have, there is a heterogeneity of these trials. We will discuss this one by one. Next slide, please. This is just a etiology, how this neurological deficit can occur. Prenatally, any infections like rubella or cytomegalo infections, or whenever there is asphyxia or hypoxia to the brain. Second one is a perinatal, any birth defects, preterm birth, intrauterine growth restriction, as Dr. Mala has pointed out. Then sentinel events and multiple pregnancy. In postnatal, any trauma or any cerebral infections. Next slide, please. So then we are talking about the guidelines and recommendations. So there are so many guidelines, FIGO guidelines, and these FIGO guidelines are the good practice recommendation we all know, and it is a collaborative outcome of various guidelines they take. And so what they advise is women at risk of early preterm imminent birth from viability to 30 weeks of gestation, the use of magnesium sulfate for neuroprotection of the fetus is recommended. So in pregnancy below 32 to 34 weeks of gestation, the use of magnesium sulfate for neuroprotection of the fetus should be considered, and magnesium sulfate should be administered regardless of the cause of preterm birth. This is very important, and the number of babies in utero. So multiple pregnancy also you have to give. When the birth is planned, the magnesium sulfate should commence as close as possible to 4 hours before birth. If delivery is planned or expected to occur sooner than 4 hours, even then magnesium sulfate should be administered, as there is still likely to be an advantage from administration within this time. The optimal regime of magnesium sulfate for fetal neuroprotection is an intravenous loading dose of 4 grams that is administered slowly over 20 to 30 minutes, followed by 1 gram per hour maintenance dose. And this regimen should continue until birth, but should be stopped after 24 hours if undelivered. Next slide, please. Then comes the ACOG. ACOG also recommends that magnesium sulfate reduces definitely the risk of cerebral palsy, and it has also taken account of various available evidences. And they also say that it should be given before anticipated early preterm delivery, which also they have endorsed that it reduces the risk of cerebral palsy. Next slide, please. Now, this is recommendation again for the neuroprotection of magnesium sulfate. Various authorities also have endorsed the role of magnesium sulfate. So they have endorsed that. They also tell that the fetal indication for delivery at 23, that is a lower limit of viability, 23 to 31 plus 6 weeks of gestation, they should receive magnesium sulfate. So exclusion is, of course, when you cannot give magnesium sulfate, we all know. I have already put it. That is evidence of renal insufficiency, myasthenia gravis. It is, of course, the magnesium sulfate is contraindicated. We all know that. Next slide, please. WHO recommendations also it is a strong recommendation that magnesium sulfate should be given whenever there is an imminent preterm birth before 32 weeks of gestation for prevention of cerebral palsy in infant and child. And these also they have endorsed for singleton and from the Australia, New Zealand, Canada, Ireland, Belgium, United Kingdom, FIGO, WHO, France, and USA. You can say that they have given loading dose as 4 grams and early, and only France and they have not specified this WHO, but 4 gram is the least starting loading dose for all the recommendations. Only thing is, you can see here WHO stops at 12 hours as well as France recommendations. These are up to 12 hours. So the whatever the loading dose remains the same, that is 4 grams followed by 1 gram per hour until birth. and not more than 24 hours. That's what is we follow in the whatever guidelines we follow here. Next slide, please. Now, as I told, the contraindications and precautions we have to take whenever we are giving magnesium sulfate. The major contraindication is a myasthenia gravis, since it can precipitate the severe myasthenic crisis. Myocardial compromise or cardiac conduction defects we should not give, because it is anti-inotropic effects, and impaired renal function, which is defined as serum creatinine greater than 1 milligram per deciliter, as magnesium is eliminated by kidneys. So we have to maintain the proper GFR, that is 30 ml per hour or 100 ml per hour per 4 hours. So that has to be maintained, and we have to monitor the magnesium sulfate whenever we are giving we have to see for the patellar reflex, as we do in eclampsia. The same protocol we follow whenever the magnesium sulfate is also given as whenever we are giving for the neuroprotection. Next slide, please. Yeah, there are n number of clinical trials they have done with the magnesium sulfate, and they discuss about the magnesium sulfate and their effects on outcomes. Next slide, please. So in India, they have studied the efficacy of antenatal magnesium sulfate neuroprotection in extreme prematurity. Comparative observational study, the 100 pregnant women who had preterm birth in interventional group, as the routine our loading dose 4 grams, followed by they have given loading dose of 4 gram in 100 ml of normal saline over 30 minutes, and preferably 4 hours prior to preterm birth. And maintenance dose was not administered in these patients. In control group, no magnesium sulfate was given. And what was the outcome they studied was the adverse clinical outcome in magnesium sulfate and control group. The result was the infants who received magnesium sulfate were less likely to require invasive mechanical ventilation compared to the control group, and magnesium sulfate had a protective effect on the need of invasive ventilation in preterm infants. Neonates with antenatal exposure of magnesium sulfate had more days free of respiratory support in the first 28 days. So these are the important things they have observed in this trial, this clinical trial. Next slide, please. This is another trial where it was a prospective randomized control trial where 50 pregnant women who had a preterm birth, where 4 gram loading dose was given. And again, here there was no maintenance dose was not given. And this study was conducted in medical college in the last year. And the inclusion criteria was all pregnant women of gestational age 28 to 34 weeks of labor who would deliver in next 24 hours. So the next maintenance dose was not given, only that first loading dose was given. Next slide, please. And the result was the Thompson score, which revealed that the 60% of the newborn had a normal neuronal development, whereas 38% had a mild and 2% had a moderate neuronal abnormalities. The infusion delivery interval which was done was 80% deliveries occurred after 13 hours. So this was a outcome which was studied about the neuronal development. Next slide, please. Even they studied of the Apgar score, and the Apgar score was 1 minute. At 1 minute was 5.78 at 5 minutes, and at 5 minutes it was 7.44, and 92% of the neonates were normal. So magnesium sulfate, which was given for the fetal neuroprotection before preterm birth, avoids cerebral palsy and lowers the combined risk of fetal and infant death or cerebral palsy. Significant neuroprotective advantage to the neonate, and it is safe drug to use in antenatal women. That was the conclusion. Next slide, please. Yes. So there was a trend towards reduced risk of in the magnesium sulfate group for intraventricular hemorrhage and neonatal hypotension, hypothermia, length of NICU stay. Intraventricular hemorrhage was less frequent and less severe in babies exposed to antenatal magnesium sulfate over control. So the conclusion is, again, the magnesium sulfate is a safe drug. We can use in antenatal women at risk for impending preterm. Antenatal magnesium sulfate confers significant neuroprotective advantage to the neonate, and it is time to start using magnesium sulfate in our clinical practice for neuroprotective intent in all our extreme preterm birth. Next slide, please. So this is another large trial, comparatively the earlier trial, where they studied around 1,000 plus women. 1,062 women with fetuses younger than 30 weeks of gestation for whom birth was planned or expected within 24 hours were enrolled. Here they gave 4-gram loading dose, and then followed by a maintenance infusion of 2 gram per hour for up to 24 hours. In control group, isotonic sodium chloride solution was given, and the rates of total pediatric mortality, cerebral palsy, and the combined outcome of death or cerebral palsy at a corrected age of 2 years they studied. Next slide, please. So the result was in magnesium sulfate group, the total pediatric mortality, cerebral palsy in survivors, combined death or cerebral palsy, gross motor dysfunction, combined death or substantial gross motor dysfunction or pretty less. So you can see here the figures as well. And the magnesium sulfate given to a woman immediately before very preterm birth may improve the important pediatric outcomes. No serious harmful effects were seen in this group. Next slide, please. And this is our PREMAC trial, which is mentioned. That is effect of magnesium sulfate on mortality and neurological morbidity in very preterm newborn with 2-year neurological outcome, which is again a RCT, where 573 women less than 33 weeks whose birth was planned or expected within 24 hours. So here the interventional group received a single injection of 0.1 milligram per liter magnesium sulfate, that 4 gram over 30 minutes. In control group, they have given isotonic sodium chloride solution. And the result they studied was the decrease in all primary endpoints like total mortality, severe white matter injury, and their combined outcome, and of all secondary endpoints, that is motor dysfunction, cerebral palsy, cognitive dysfunction, and their combined outcome at 2 years of age in the magnesium sulfate group. Next slide, please. The decrease was significant for gross motor dysfunction and combined criteria, that was death and cerebral palsy, death and gross motor dysfunction, death and cerebral palsy, and cognitive dysfunction. So given its beneficial effect and safety for the use for prenatal low dose magnesium sulfate for preventing neurodisabilities of very preterm infants should also be discussed, either standalone treatment or as a part of combination treatment, at least in the context of clinical trial. So this very low preterm, we need to counsel the patient because we have to see the outcome as well. Next slide, please. So there are again meta-analysis of various 5 RCTs with 5,235 patients. The effect of antenatal exposure to magnesium sulfate on neuroprotection and mortality in the preterm infant, this is a meta-analysis. They concluded that fetal exposure to the magnesium sulfate in women at risk for preterm delivery significantly reduces the risk of cerebral palsy without increasing the risk of death. Next slide, please. So the Cochrane review. This Cochrane review, which is published in 2009, also endorses that it has magnesium sulfate reduces the risk of cerebral palsy in the child, and the substantial gross motor dysfunction, and definitely at the 2 even that is motor dysfunction. How they study is inability to walk without assistant at 2 years of age. So magnesium sulfate had no significant effect on pediatric mortality. That was the outcome which was published Cochrane review. The number of women needed to be treated is around 63. Next slide, please. These are the Canadian guidelines, that is SOGC clinical guidelines, that is for women with imminent preterm birth, less than 31 plus 6 weeks, antenatal magnesium sulfate administration should be considered for fetal neuroprotection. Then what is imminent preterm birth? That is defined as high likelihood of birth due to one or both of the following conditions, that is active labor, more than 4 centimeter of cervical dilation, with or without PPROM, and planned preterm birth for fetal or maternal indications. Next slide, please. So in summary and recommendation, in pregnancies at high risk of preterm birth, within 24 hours, administration of magnesium sulfate is recommended. In utero exposure to magnesium sulfate before early preterm birth reduces the incidence of cerebral palsy and severe motor dysfunction of offspring. Then upper and lower gestational age to define is very important. Limit magnesium sulfate therapy for neuroprotection to pregnancies that have reached a gestational age at which mother opts for a neonatal interventions, but are less than 32 weeks of gestation. Next slide, please. Emergency delivery. If the emergency delivery is necessary, it should not be delayed to administer magnesium sulfate. Now, what about the retreatment? If the patient does not give to birth after an initial course of magnesium sulfate therapy, we suggest not to retreat. This is a grade 2C recommendations. And tocolysis, if you want to do tocolysis, which is indicated because of preterm labor, the most effective agent with the most favorable side effect profile should be chosen. And we recommend endomethacin. Whatever the guidelines say, but endomethacin is a preferred because whenever we combine nifedipine as well as magnesium sulfate, we know the side effects. So the endomethacin is a preferred tocolytic agent. Antenatal corticosteroid, a course of antenatal corticosteroid should also be administered according to the standard guidelines. So this is what I feel that should be summarized, and it is recommended in women at risk of every preterm birth, significantly reduces the adverse clinical outcomes, and also reduces the pediatric mortality, cerebral palsy incidence. Next slide, please. So, despite the clear benefit of magnesium sulfate, despite the well-established superiority of the magnesium sulfate management of the severe preeclampsia, eclampsia, and preterm labor, it continues to be used suboptimally in India. And there are various solutions nowadays. We all know listens have come with the 4-gram solution in 100 ml. So it is very easy to use and monitor also. I just have to have some comments from others also. How many of us really use magnesium sulfate for neuroprotection? We have to publish another larger trials about this. And most, I have some doubts about the lower and upper gestational age. No doubt, they say about the lower limit. For the patient, for the lower limit of viability is still to defined, and peri-viable, what we call it as a peri-viable birth, that is a limit of viability still to define, because we have to confer and we have to discuss with the neonatology team, and jointly we should counsel the mother also about the possible management strategies whenever we define about the lower limit, when we can salvage these infants and then administer neonates and administer the magnesium sulfate for the neuroprotection. So none of the randomized controlled trials of the magnesium sulfate for neuroprotection included the pregnancies at less than 24 weeks of gestation. Although all the prospective observational studies, they have included the pregnancy as early as 22 weeks onwards. And the upper limit I wanted to comment on is we limit the use means between 30 less than 32 weeks, because majority of the data of our randomized control trial are derived from the pregnancies of less than 32 weeks. There are no trials of 30 term or 32 weeks because there are no data and there is no value. The potential value of the magnesium sulfate at term infants is unknown. I don't know about the studies in India because I did not find much time to study those. But what in our practice by Dr. Pratik, and it is really interesting. And the retreat, many people have commented, and you should not see, you have given the magnesium sulfate and the patient has not gone in labor and these are the my whatever the views on this topic. Thank you very much, Dr. Pratik, to bring in
Thank you, Dr. Vidyatopi ma'am, for an elaborate and exhaustive presentation on magnesium sulfate.
me, and really
role.
it is a thought-provoking topic about me.
Yeah, thank you again, Dr. Vidyatopi, for being here and for explaining to us in elaborate detail about fetal neuroprotection. I see Dr. Kalpana is here. Ma'am, any closing remarks on this talk?
Yeah, that was a wonderful deliberation as usual by you, ma'am. It was really useful for all the delegates who had joined in huge numbers, mainly because of the efforts by Pradeep sir. Thank you, ma'am. Even though we couldn't meet you personally, physically, at least we had a chance to meet virtually the day before the great conference. Thank you, ma'am.
Thank you, Dr. Kalpana. If Dr. Lakshmi Madam is here, any closing remarks from her, Dr. Mala? I see that there are some questions in the chat box, but most of them have already been addressed by both the speakers. There was one question regarding how we can prevent fetal growth restriction from happening. So that was covered in elaborate detail by Dr. Mala. We also have a couple of questions regarding carbetocin, but I think that's not relevant to today's talks. We will probably address that in a different program. I'm very happy to announce that we have fantastic attendance for today's event. We've crossed 1,400 delegates, which is amazing. It speaks volumes for the quality of our speakers as well as the topics. The topics actually are something which are of practical and clinical significance. I've just been given an update. It's now 1,759 exactly. So that's something which is unprecedented. We used to see those kind of volumes only during the pandemic. During COVID, we used to see those kind of attendances. So that's amazing. And thank you so much, everybody, for being here with us. If there are any closing remarks, I would request the speakers to please speak. Otherwise, I will propose the formal vote. Dr. Vidyatopi, ma'am. I think she's facing some internet issues.
Yeah. Internet is slow.
Yes, Dr. Pratik, I must congratulate. Hello.
Yes, ma'am, please go.
Hello, am I audible?
You're audible, ma'am.
Yes.
Yes.
Must congratulate Dr. Pratik only to bring in such a new things and new topics, and they're for debate. Really, I feel so, and thank you again for bringing me and calling me. I appeal all the ICOG fellows who have joined here to vote for me as well as Dr. Pratik. We are again contesting for the ICOG Governing Council member this year. Thank you very much.
I see Dr. Mala has taken time out from the OT. She's back with us. Ma'am, please
Yes,
unmute.
she was in
Any
OT.
closing
Yes.
remarks? Yes,
Hello.
Dr. Ma. Yes, ma'am, we can
Yeah,
hear you. Please
it
go
was
ahead.
really a great session and really thoroughly enjoyed today's session with Dr. Vidya who'll be going into great details of tackling the neuroprotection with MaxSelf and how it can impact the neurocognition and neurodevelopment of the growth restricted fetuses and how important it is. Thanks, Dr. Vidya, for that excellent scientific deliberation.
Thank you, Dr. Mala, for being with us. Dr. Kalpana, any closing remarks before we close the session?
It was wonderful talks by great speakers, and it is so unique that two are going for ICOG chairs election and two are going for chairperson election. So thank you, sir, for the wonderful opportunity.
Thank you, Dr. Kalpana. I think at the end of the day, I need to place on record my gratitude to our backbone, Science Integra, Subhu, Shrutika, who is here today, the entire backend team. I will not be able to name each and every single person. But thank you for putting together such wonderful academic events for all of us, especially in this experience series. Today we had the theme of the fetus in focus. We had two fantastic chairpersons. Our chairperson of ICOG, Dr. Lakshmi Srikhande, graced the occasion. She was here for quite some time. Dr. Kalpana is joining us despite being very busy organizing the Yuva Foxy. We'll see her in person in a day or two. Thank you so much for being here. Two fantastic talks by Dr. Mala Srivastav on delivery considerations in fetal growth restriction and Dr. Vidya Thobi on fetal neuroprotection. I must also place on record my gratitude to all the delegates. I see Dr. Lakshmi is joined in. Yes, ma'am.
Pratik, am I
Yes, ma'am.
audible?
Yes, you're audible. I was just
Voice is
presenting the vote of thanks.
no,
So
no.
thank you
I
for
just
coming
heard.
in time.
But is my voice clearly audible?
Yes,
Because
ma'am.
when I
Very clear.
logged in, it
Loud
was
and
not
clear.
loud and
Loud
clear.
and clear.
Yeah.
Yes.
So as usual, it was a very informative webinar and a very focused webinar, Pratik, and very informative and useful for all the delegates. So keep doing such focused webinars, and we all are there with you. Thank you,
Thank you,
Pratik.
ma'am. Madam, 1759 attendance
Great,
today.
great,
So I must also
great.
place on record my gratitude to Glisten, who are our academic partners in this series. They've been doing events with us for the past year or two. They are the makers of IV-MAG, which is magnesium sulfate, which we tackled today, injection I3, which is iron isomaltoside, a newer variant of parenteral iron, which you've heard other speakers talk about at other events, and of course, Carbacin, which is their own version of heat stable, room temperature stable carbetocin, which has revolutionized the management prophylaxis of PPH. So thank you everybody who logged in. We hope to see you at the next event. Until next time, goodbye, God bless, and thank you very much.